I'll call to order the Green Mountain Care Board's hearing of December 11th, 2024. One presentation today by Michelle Degree, our Health Policy Project Director, and Lindsay Kill, our Deputy Director of Health Systems Data and Analytics. First, I'll move to approve the December 9th, 2024 meeting minutes.
Second.
All in favor of approval, please say aye.
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 The minutes are approved. Ms. Degree, are you here and ready to go?
I am here, Chair Foster, and just a quick update with our inclement weather. Lindsay is not able to join today, so it is just me pinch hitting on a couple of items, but I will do my best to get through everything for today. I'm going to go ahead and share my screen. Are you all able to see that, and can you hear me okay? All right, thank you, Jess, for the thumbs up. So as the slide indicates, we're here to talk about the benchmark recommendation for the Medicare ACO program for 2025. Quick agenda. We're going to start with our staff recommendation for the benchmark. I'll go through some slides that you all have seen and are quite familiar with, as this is the 8th year, I believe, that we've done this now. So quick background and experience to date. So with that, sort of here's the initial spoiler, which is staff are recommending that that we use the maximum allowable trend for OneCare Vermont's Medicare benchmarks. So per the agreement, those are 0.2 percentage points below the national trend, so that for 2025 is 4.0 for non-ESRD and 7% for ESRD. This results in a request for advanced shared savings amount of $10.3 million to fund the Blueprint for Health and SASH. This number is consistent with what you saw in OneCare's 2025 budget submission, specifically, I believe, tab 6.11. Again, you've seen these before, but some trade-offs for kind of our staff recommendation of maximum trend. Positives, we know that hospitals are financially fragile. Maximum trend, of course, then also is our way to increase the amount of federal dollars available through the all-payer model, specifically for Blueprint and SASH. A con here, which we'll talk about in a little bit more detail later, but then ultimately a lot more detail once we have more claims run out, is potential for maximum trend to endanger the ability of the state to fulfill its financial targets under the all-payer model agreement. Just a reminder of past trend limits and decisions. For the most part, within this sort of construct, we've recommended maximum trends throughout, with the exception of sort of those COVID years. And again, a little bit of background on the all-payer model agreement. So just thinking about these sort of separately, but then talking about how they work together. We have the Vermont all-payer ACO model agreement between CMS and the state. OneCare Vermont has its own agreement, often referred to as the participation agreement, between CMS for the Medicare component of their attributed lives and OneCare Vermont. So the agreement requires the board to set the benchmarks for the ACO's Medicare program. And those benchmarks are approved by CMS prior to the performance year. They have to be approved, which is why we've got this conversation today. We have a vote notice for next week, and then can get the proper paperwork rolling prior to the end of the year. So again, just a reminder of how we measure the all-payer model. We've got 3 areas of performance that the board specifically monitor and report on for our federal partners as part of the agreement. Total cost of care being the sort of financial component. Scale, which is the proportion of the population aligned to the ACO. And you'll recall we no longer need to meet the thresholds within the agreement for scale, although we do still continue to report on it through the duration. And then quality is sort of that third component that we talk about. And this is state's trajectory towards improving patients and provider outcomes. And then again, those measures are sometimes ACO specific, as you all know, and some are more statewide. And then there are quality components within the ACO's separate sort of contractual agreements with payers as well. So breaking that slide out a little bit in more detail, talking specifically here about total cost of care and that financial component, and where the Medicare ACO aligned population is sort of our entry point into regulation for the Medicare beneficiaries here. The Medicare benchmark is how we fund the Medicare piece of Blueprint for Health, and then the support and services at home programs. All-payer model financial targets. So there's state accountability and then sort of the board's duty separate from that. So state accountability is the all-payer total cost of care per capita growth. This was set in the original term of the agreement. So back when it was signed in 2016 and was meant to be a 5-year agreement. So through 2022, for an average threshold of 3.5 to 4.3 in that compounding annualized growth rate. And then using 2017 as sort of our starting point for that. The Medicare total cost of care per capita growth needs to be, again, 0.2 percentage points to 0.1 above national projections to sort of fall within the Medicare constraints of the all-payer model agreement. And again, the board's duty here is to set the ACO Medicare benchmarks, or those annual targets for Medicare beneficiaries who are attributed to the ACO. ACO financial targets here. So Medicaid and commercial payers negotiate annual financial targets with the ACO in their contractual agreements. And you all, and with the guidance of Michelle Sawyer and her team, use the ACO oversight process to monitor how those targets relate to the all-payer model financial targets. And Medicare specifically relies on the board to propose annual financial targets for the ACO on its behalf. And the agreement does include some of those criteria, which I've talked about and I'll go into a little more detail. And CMMI approves or can request modifications to the proposal. Ultimately, I do not recall a time when CMMI has requested modification to the board's approved rate. I know, the time of the year is a challenge with this. We're trying to get as much data as possible, but also needing to sort of fit within that time frame to have a 1/1 start date for the benefit of the ACO and their operations. Couple of components within the benchmark and how we get to the dollar amount. So we've got historical experience, which is estimated medical claims spending, in this case in calendar year 2024, for beneficiaries who would have been attributed to the ACO based on the ACO's provided 2025 network. We call this the reference population. Then there's a number of ACO aligned beneficiaries. So this is the number of bennies that ACO will be accountable for in 2025. Of course, we always see attrition in this number based on when the data are run and the start of the performance year. And then there's the trend. So again, this is the decision that we're talking about today. And that is equal to our financial target for the ACO. The benchmark ultimately becomes a dollar amount, which then is kind of, you can think about it in the PMPMs for the two populations I talked about earlier, ESRD and the non-ESRD populations. So again, allowable benchmark trends. Per the agreement, one of the criteria is that we need to set a trend at least 0.2% lower than projected growth for Medicare fee-for-service nationally. This comes from the Medicare call letter. We call this the USPCC growth, I think a term that many are becoming familiar with as we work through some discussions on the AHEAD model as well. So an example here for 2025, the national USPCC trend for Medicare expenditures is 4.2. So under that arrangement, Vermont's target trend per the agreement, or maximum trend per the agreement, would be 4%. End-stage renal disease, we set a separate benchmark for beneficiaries who are eligible for Medicare due to end-stage renal disease. So for example, here again, the ESRD trend is 7.2%, so ours would be about 7. Ultimately, there are very few beneficiaries eligible due to ESRD, but their average expenditures are much higher. I believe in the 2023 settlement, which is the most complete year of data that we have, it was just over, I want to say 130 who attribute, beneficiaries who attribute through the ESRD program. We always want to talk briefly just about benchmarks and the AIPBP, sometimes is a point of confusion. As you most certainly are aware, Medicare offers prospective payments. The payments are designed as the cash flow mechanism to provide stability to providers. That said, ultimately, Medicare's AIPBP is reconciled to what would have been paid on behalf of attributed beneficiaries. So when we think about the all-payer Medicare total cost of care for the ACO, we're talking about fee-for-service payments plus the AIPBP claims. This calculation is done separately from the benchmark and is reconciled independently. I want to talk briefly about advanced shared savings. So again, we call the advanced shared savings is what all of us think of as the blueprint and stash dollars. So the investments there ended in 2016 for the Medicare component of those investments. The all-payer model agreement included provisions to allow for their continued funding through Medicare by way of their contract with OneCare Vermont. So back in the first performance year, it was actually performance year 0 of the model, the agreement provision started at $7.5 million, and that has been trended at the board approved rate throughout the duration of the agreement. The funding is attached to the benchmark, but it doesn't represent performance risk, and the shared savings advance is ultimately reconciled at settlement. So this is how the advanced shared savings fits in. So the performance risk piece we talked about before, and then we have the advanced shared savings piece, which is sort of just an addition of the funds, which then informs the total benchmark. I'm going to talk briefly about experience to date. We just want to show sort of the OneCare participation and kind of that delta between the prospectively aligned population and those that are ultimately included for settlement. So the ACO program itself, the Medicare ACO program, limits which beneficiaries are included in financial settlement. The beneficiaries have to have maintained eligibility for the entire performance year or until they pass away and receive 50% or more of their primary care services within the ACO's service area or eligible providers. As more people opt for Medicare Advantage plans, more beneficiaries then lose eligibility. So helps to explain some of sort of the delta that we're seeing there. A quick overview of settlements to date. Just we always like to point out sort of what the advanced shared savings amounts are and how they fit in. This goes through 2023 because those are the completed settlements that we have. For 2024, the advanced shared savings amount was just over $9.9 million. So when I talk about about 10.3 million for this year, it's thinking about that number trended forward at that 4% rate. We do want to note a caveat for 2023. On July 3rd of this year, CMS proposed a rule for the purposes of holding the ACO harmless for what they call significant, anomalous, and highly suspect catheter billing in terms of 2023 performance year shared savings calculations. As a result, all claim line expenditures for urinary catheters with specific HICS codes, if anyone wants me to write them out, I certainly can, were excluded from the performance year expenditures, again, for purposes of the shared savings calculation. So for OneCare Vermont, in total, just over $4.8 million were removed from the total cost of care as part of this CMS ruling. It is important to note that without this policy change, because of the cost of those services, the ACO would have likely come in over the adjusted benchmark, and in that instance would have likely owed CMS as shared losses instead of shared savings. But again, this was a national fraud case. I've linked the rule there if anyone is more interested in learning about that. But also to note that because there was no resolution for the claims before 2024 performance year occurred, because these occurred in 2023, you'll continue to see this adjustment when we talk about 2024 settlement as well. So next fall, August, September timeframe. I do want to highlight that this all does tie into our all-payer model total cost of care performance. Based on preliminary estimates for 2023 runout, which is not complete, and what we know of 2024, it is possible that the state will exceed the 4.3% compounded annual growth rate target. The state agreement, of course, does implore the board to steward the Medicare benchmark to help meet these targets. The data that we have and that we've done some digging on demonstrate that the Medicare ACO expenditures are not what is driving this growth. And as such, staff continue to recommend the maximum trend for the Medicare benchmark, again, 4%, to continue the maximum federal funding for Blueprint and SASH programs. We know that the performance on the all-payer model total cost of care is of interest, and Lindsay and I do plan to discuss this in detail at a future board meeting when we have more complete claims run out and can more precisely sort of talk about what we see as driving those changes. That will not occur most likely until into the new year. We have some pretty significant claims lag at the moment. So again, just to close out, staff are recommending that we use the maximum allowable trend for OneCare's Medicare benchmarks, which equates to an advanced shared savings of just over 10.3 million. You can certainly break it out into Blueprint and SASH, and those are the numbers there. And again, this is also what was requested from OneCare Vermont in their budget. And that's all I have for you today. Here for questions, though. And I've got Lindsay on the phone if I really need her.
Okay. Thank you very much, Michelle. One quick, brief little question. The quality adjustments that were on slide 21 or 22? 20 maybe? Yeah, 20. When do we get the data on whether or not there will be quality adjustments for 24?
Well, you won't see that until settlement, so same time frame. It'll be around August. It's typically in the fall of it'll be 2025 at that point.
Fall, right, okay.
Because we just got settlement for 23 and presented that to the board, or I sent that to the board November.
Okay. And then the total cost of care run out, you said will be around January-ish when we get that data?
We're hopeful. I know we've done some, I don't want to call it nagging, but requesting for some data. And, some of this is sort of multi-party. It's not any one specific, or Lindsay can answer. Go ahead, Lindsay.
Hi everyone. Right now, the time frame for receiving the full run out of 2023 is the end of winter, like so March time frame, and then plus whatever time that our contractors need for analyzing the data. So I think safely looking at April, if not slightly later. It's very delayed, unfortunately.
And when do we usually get it?
Normally we have the full year of, we have all incurred claims plus at least 3 months of run out by now, for sure. And sometimes we even have Q1 of 2024.
Thank you.
Yep.
I didn't have any other questions. Thank you. And I appreciate the staff's recommendation. Overall, I think it makes sense for basically essentially balancing increasing federal dollars versus hitting these targets. I think where we are as a system, increasing those federal dollars as much as possible is an important step to take and consistent with what we've done in the past. So just directionally speaking, I plan to support that. And I have nothing else. Thank you. Any other board member questions or comments? Great. I'll turn to the healthcare advocate for any questions or comments they may have.
Just that we support staff's recommendation. Thank you.
Thank you. And I'll open it up to public comment for any feedback on the presentation today or the staff recommendations via raise the hand. Okay, seeing none. Of course, people can always write in if they have any thoughts on any of this, and we appreciate that. Ms. Degree and Ms. Kill, thank you very much for the presentation today.
Thank you.
I will turn to the healthcare advocate for a comment they wanted to make relating to open enrollment.
Thank you, Mr. Chair, and I just want to recognize Senator Williams. Welcome. Hey, I thought it made sense to at least spend a minute looping back to you guys on this year's open enrollment, because some of it is really a direct result of decisions made by you. I know it's not where your heads are at. It is significantly where a full half of the HCA's head is at. You know, the helpline is, you know, busy at this time of year, really focused on open enrollment. And so just a couple of brief updates for you to hear how it's going. First off, I know Medicare is not in your area of jurisdiction here, but we just ended the Medicare open enrollment on December 7th. And this was a hard open enrollment period for everyone who was trying to help Medicare beneficiaries and for Medicare recipients. I think the departure of the Part C plans that left the state, on top of various other things, significant rise in costs of Medicare supplemental plans. This was really hard for the HCA. It was particularly hard for the SHIP agencies, for the area agencies on the aging, and I think very hard on many Medicare recipients. So that's closed, though. That ended on the 7th, and we are still in the midst of the QHP open enrollment. And there are two significant dynamics at play this year, this open enrollment for the QHP, which you'll be familiar with. One of them being silver alignment. The silver loading that the board passed really worked. It significantly, it made gold plans less expensive than silver. And as a result, is given many, many Vermonters more buying power and ability to get a richer plan. So that all worked on paper. We'll see how it worked in actuality when we actually get the numbers. And that, of course, only applies to the individual market. There are there was an active effort by DEVA and with partnership from the HCA to actually help people get into the right plan, moving people from silver to a mapped gold. And that also appears to have worked. So many people, we helped them get in the right plan. The other significant dynamic at play this year is the price variation between the two carriers. We've seen this year, in various years, price differences before, but we've never experienced it to the degree we experienced it this year. And it's enough to have raised some real concerns for us. Because of the way the subsidies, the premium subsidy is based on the second lowest cost silver plan, when there's a big price difference, it can really expose even very low income people to big premium increases. And so as a result of that, we became really concerned about the people who were on the more expensive carrier below 200% of poverty. There's about 4,000 of them. So these are people who are on cost sharing subsidy. And so we want them to stay in silver. They get a more generous plan staying in silver. But we saw for that 4,000-ish people premium increases that we thought none of them could afford to pay. And they could fix that by switching to the other carrier. But it's really hard to get people to shop, particularly this population of people to shop. So I don't have numbers today. I'm going to get some initial numbers on Friday, but I just wanted to let you know that that's a group that we were particularly concerned about. And with some partnership with DEVA, we've been trying our best to reach out to them and help them understand the dynamics. And of course, the price variation between the carriers plays out in both the individual and small group. And I don't have any insights about what's going on in the small group other than recognize that we don't advise small employers, but I still hear a lot of concern from small employers about the challenges in the marketplace today, and the price increases. I think that is significantly what I wanted to give you an update on, both a recognition of good work on silver alignment. It really did work. And who knows what we'll be dealing with for next year. Happy to answer any questions or answer questions offline if people have questions.
Thank you very much, Mike. We are hearing from a lot of business owners, small group, restaurants about some of the challenges with the price increases. Certainly on our radar when we handled this and still is. I did want to point out, Mike, you're very gracious in recognizing the board's effort on silver alignment, which I also really appreciated. That was the goal, was to get people better plans for less money. And we achieved that. But I would be remiss not to recognize that that was your idea. And you brought that to us. And I thank you for doing it. And I'm glad that the board was able to take action on your suggestion that was beneficial to the state. So thank you for doing that. Any other board comment?
I didn't manage to say it, and I know everyone here knows it, but I'll just, how could I talk about open enrollment without at least saying December 15th is the deadline for people to get a January 1st plan. So we're coming up on that in a few days, but open enrollment goes through January 15th this year. So people who still need to take action, it's time.
Thank you. And we'll look forward to the data that you get on the shifts that you, and I appreciate the reach out by the agency and in your office on that. It's really important. Any other board member questions or comments for Mr. Fisher?
I just have one quick question.
I see
if I could
Walter
jump in.
has his hand up.
Oh,
Yeah,
go ahead, Dave.
Do you have any insight into what's causing the price increases in the Medicare supplemental plans?
I don't have any insight other than that it appears to be happening across the board for every payer.
Do you know if that's happening to the same magnitude outside of Vermont?
I don't know.
Uh,
Do you know? You are not coming through, Eric. You don't look muted, but it's.
You did for a split second.
It's a good question, Member Merman, and the rates of increase in that market are it's not unusual to see a 50% rate increase.
Wow. That's alarming, especially given possible policy approach change on steering people towards Medicare Advantage plans. This might be very disruptive and impactful. Thanks.
Walter, how are you?
Hey, Owen, how are you?
I'm great. Thanks. Happy holidays.
What? Oh, the holidays, yeah. It's just work days for me. Back up what Mike Fisher just said. My Medicare supplement went up $40 for next year. And the Medicare Part B went up $10. The Social Security is going up by a 2.5%, which for me is about $30. So I'm already $20 out even before the plans go in. I could not, when I called the Council on Aging to try to work with the Philly supplement plans, they didn't have an appointment. They said they were too busy. And so I asked why, and they said it was because of the UVM MMC Advantage plan that went south, so to speak. They were just too busy. They had no slots available because they had like 5,000 or 6,000 people that were on that plan. And then the rep at Blue Cross told me that their supplemental plan, I think it's the Vermont Blues or something, is going up to over $300 a month within the next year or two. And when I think another question is, what are we going to do when the Trumpers or the Trumpians get rid of traditional Medicare? Because that's where they're going. And with costs like these, nobody can handle them. How do I lower it here?
Thanks, Walter, for sharing that. Certainly, any administration change can bring changes in policy and direction, and the board and others are keeping an eye on those developments, and I'm sure the hospital industry and providers are as well, because there could be changes, but hard to predict exactly what direction the administration will go and when. But they could be very, very significant. There's no question. Any other public comment? Okay, great. Well, thanks for the presentation, and Mr. Fisher for your update. I will move to adjourn.
Second.
All in favor, say aye.
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 Aye. We're adjourned. Have a nice day.